Started the timer and here is your time. Right. So if you have read and understood, considering this communication skills session, can we begin?
I will enter the room. Wash my hand. Greet the patient. Hello, how are you today?
Yeah, I'm fine.
I'm Dr. Muhammad, one of the surgical doctor, and I would like to speak to you about an investigation that we would like to carry out for you. Are you okay with that?
Okay.
Can I confirm that your name and age, please?
I'm Smith. I'm a 55-year-old.
Okay, nice to meet you, Smith. So, what do you know so far about these investigations?
Yeah, I have done an investigation called barium mill, and something was wrong with it. So I was scheduled for another investigation. Can you please tell me about it?
Yeah, just would you please tell me, do you know anything about this?
Oh, I heard this. There is a pipe which will be put down through my throat. I'm really scared about it.
Okay, I will take it from here. Okay. This is actually called oesophagogastroduodenoscopy. Okay, this OGD stands for this. So what we are going to do, so we are going to, if you could please have a look at this paper, I'll draw something for you. We're going to set a camera through your mouse, and this will go down to your food pipe. Are you following me?
Yeah.
Okay, perfect. Then we will go your tummy and then your first part of bowel. Okay, and this actually will reflect it to a TV screen, so we will have a look inside your tummy by that way. Okay.
Okay.
And as you mentioned earlier, you have some narrowing at your foot pipe, so we are going to just dilate that area in your foot pipe. Okay. And also we are going to take a sample from your lining foot pipe. Okay, so this is the whole idea about this and OGD.
So will I be awake or I'll be put under sleep?
Actually, we can after discuss with the anesthetist. We have two options actually. Either we can just put some sort of spray to your sore throat, and other options we can be under sedation. So yeah, there
Will
are
it be painful,
actually two
doctor?
options. Sorry?
Will it be painful, doctor?
No, actually, there'll be some discomfort if you got with the spray one, but if you went for the sedation, there will be no any pain. In the both options, you will feel no pain.
Okay. So is there any risk associated with it?
Actually, there is no any procedure without any risk. So, for example, you could have damage to your teeth, and also there may be some sort of infection to your maybe chest infection, and also there may be cutting to your food pipe.
Oh my God! Will there be cut off my food pipe?
Actually, if this is not routinely happened, but you don't worry to have you don't have to worry about this. This could, because this investigation is only carried out by highly experienced surgeon in our hospital.
So what are you going to do when if there is a cut on my foot pipe?
If you just went through this, then we will just have to go a high care area. But don't worry about this. This is only investigations carried out by highly experienced surgeon in our hospital. No one otherwise is just to authorized to do such operation without an experience.
Is there any alternatives?
We have alternative which is called the barium swallow, and this actually will gonna take some serial of an X-ray. Okay.
Yeah, I have
And you
already
will
done
have
this.
This is actually another technique. You will have to just to drink some sort of dye. Okay. Meanwhile, we are going to take a serial of imaging, but
Yeah,
the difference is
I have already done that. Is there any alternatives apart from this OGD scan? Can you do just an CT scan?
I'm afraid no. Just even if we did this, what are you saying? CT scan. The difference is we will not able just to take a sample from your foot line. So I just recommended you just to go with this one.
Simple in
Okay.
dilation. Yes.
Yes.
Okay, doctor. Recently, I'm having this watering from my mouth. What do you think the cause?
Okay. Appreciate your concern. Sorry for that. So if we get back to this paper, you just have narrowing from this food pipe, so your saliva will not just go down because of this stricture. This is just prevented from going down, so that's why it's accumulates further and go to your mouth, and that's why you are keeping salivating. But you don't have to worry about this, because we are going to just to dilate this area, and then we'll just have some sort of relief.
What do you think, doctor? Do I have cancer?
I'm really appreciate your concern, but it is early to say that. Actually, that's what we are waiting for, this investigation. Just we went to have to take this sample from your foot pipe, and then we have to wait for the results. It's just early to say that. We have to just to know the type and where it's coming from actually.
Okay, so how long it will take to get my result?
Actually, it will appear about 2 weeks, but I will definitely will just call you when the result is out.
Can you tell me it is an advanced or localized by this investigation?
I'm afraid I don't have this information right now, but we have to just wait for the result until the
No,
result is
no,
appear,
no,
and this will give all.
I was,
Yeah. Yes.
no, I was asking, can you guess whether it is an advanced stage or is localized by doing this OGD scan?
By doing this, we will not give the whole idea about this your disease. Okay, we have to
Okay.
just to take this sample just to know the type of this cancer. Okay, it could be
Okay.
benign, could be malignant. So we just have to wait for the results until we make sure where it's coming from.
Okay.
Do you have any further questions? Anything that you would like to?
Can I take food before doing this procedure?
That's a good question. Actually, if you you have to just to stay fast. You don't have to eat anything at 12 midnight if you are going to have this procedure at the investigation at the morning. Okay, but if anything that has delayed this investigation, then you have to just to take small amount of food until the 10 a.m. But you don't have to eat or drink anything 2 hours before this investigations.
Okay. Do I have
Am I
to
making
accompany
myself clear?
anybody? Yes,
Sorry.
yes. Do I have to accompany anybody during this procedure?
If you went from the sedation one, then definitely you have to just get someone to drive you home safely in the next 24 hours. You don't have to drive by alone, okay? And also,
Okay.
if you went from the spray one, then you just have to avoid drink hot drink, just because you are going to have a numbness in your mouth, so you will not feel this hot drink. This could cause some sort of burn to that area. Am I making myself clear, Mr.?
Yeah, but which protocol do you follow regularly? I mean, a spray one or the sedation one? Because I have to accompany somebody if you use sedation.
Yeah, if you have someone like a friend or family member and he will going to drive you home, then I just recommend you just to go with the sedation one.
Okay.
And
Okay.
yeah, if you have you just have to don't have to stay at the hospital, but you only have to stay 2 to 4 hours only after the
Okay.
sedation. Yeah, if you went from the spray one, you will go home directly after this investigation.
Okay, doctor.
You have any further question?
No, doctor.
Can we please just summarize for me what we have went through, just to make sure that you have understand me well?
Yes, please go on.
Okay.
No, in this one, you
So
have to make the patient sign the consent form. If
yeah,
patient
yeah,
agrees. Yes.
yes, but just after the summary, can
Okay.
maybe. Okay.
Yeah, you can just make
So
patient tell you.
yeah, just please tell me that what we have went through, just to make sure that you have understood me correctly.
Oh, you are asking me to summarize it?
Yes, just
Yeah.
what we have went through.
Yeah, you have told me that there will be there will be a camera which will put through my throat and through my food pipe to and take some sample of it, and you have told about some complications of the procedure, and
Yeah.
you told me that you could put me under sedation or give me some local spray,
Yes.
and you have told me to not to take any food or water for 2 hours prior to this procedure, and
Yeah.
I could accompany somebody if somebody is available. Is it right?
Yes, marvelous. Just last one thing, you have to sign this document for me that's stating that you have understood everything that I have explained to you about this investigation. Are you okay with that?
Yeah. Can I call you if I need something else to know before the
Yes,
procedure?
definitely. We are all here just to support you and have you a hand at any time. If you have any further questions, please don't hesitate to contact me. I will leave my phone number with the nurse. Thank you so much for your time.
Thank you.
Thank you. Please your question. Right, so if you have read and understood considering the critical care scenario, can you please tell me how would you manage this patient?
Okay, I'll manage the patients using the CRIPS protocol.
Yes.
So I want to check the airway
Yes.
and ensure that the patient is breathing. If he's breathing, then that's fine. I also want to assess the breathing. By assessing the breathing, I want to count the respiratory rate. If the chest is, if the air is coming out from his nostril or not. And then if there is no breathing, I want to do, and also do mechanical ventilation for him. I would assess his cardiovascular system by measuring his pulse, the BP also, by counting the pulse, measuring his BP, and then set IV lines for him, take blood samples for full blood count, electrolyte and creatinine,
Yes.
and then give him fluid. Then I will give him, he's semi-conscious, so I will check for that neurological deficit that he may have. Then I will do a control exposure to examine him. I will give him, I will also pass NG tube for him to decompress his abdomen, and then pass urethral catheter to monitor his urine. I will give him analgesics to control the parenteral analgesics to control the pain, and also give him commence him on antibiotics and proton pump inhibitor. Then plan him for operative surgery.
Yes. Right. You instantly did the chest X-ray of this patient, and it showed gaps under the diaphragm. Here, if you can tell me what you can see and what would you do next? What would you decide to do?
Okay, there is here under the diaphragm on both sides of the diaphragms. Because of this here under the diaphragm, it shows the possibility of a perforated viscus. And then one of my first differential will be a perforated duodenal or gastric ulcer, because of the history of use of NSAID that the patient has been using for a long time. So because of that, after he has been resuscitated, I will plan him for laparotomy.
Yes.
And then
before you go for the laparotomy, you would have to take the consent from the patient. What are the ethical issues that you'll face while taking the consent, as patient is semi-conscious?
Yes, for this patient that is semi-conscious, and he lacks capacity to give consent. So I will take consent from 2 consultants to sign the consent form on his behalf.
All right. What would you inform the staff, your working staff, about the patient? What type of surgery is that? Is it an immediate, or is it an urgent, or is it, how would you categorize the procedure?
Immediate urgent surgery.
Urgent, okay.
Urgent surgery.
Yes, is there a definition? How do you classify it? When is it called urgent and not an emergency?
Yes, it is immediate in patients that needs the surgery to save their lives, so that they are like rupture aortic aorta, or a bleeding vessel in patient is losing a massive blood, or that organ injury that patient is using massive amount of blood. Then for the urgent are those ones that the surgery should be done usually around within 6 hours of making the decision to operate the patient. Patient can still be stabilized properly, and then go in for the surgery.
Okay. Who should make the decision about the surgery or the procedure that you will carry out?
Is the managing team, the doctor.
Okay. What are the other differential diagnoses that you'll consider with the perforated viscus?
Yes, the other differential diagnosis could also include a ruptured diverticulitis, and then a ruptured appendicitis could also be another diagnosis.
Yeah. What are the pathologies or the possibilities of differential diagnosis that you'll consider for the large bowel?
Okay, the large bowel, and a perforated bowel cancer, also a perforated diverticulitis.
Yes.
Could also be another differential diagnosis.
Pseudo obstruction, anyway. Okay. Right. You said patient has abdominal pain. How would you manage the pain?
Okay, for the management, I'm going to use the parenteral analgesics to manage the patient. I will give patient paracetamol IV and then
Yes.
opioid treatment also for the pain. And then I will, because of the chronic use of NSAID in the patient, I also want to give patient a proton pump inhibitor.
Okay. Yes. Right. Yes. How would you take care of the TPN? How would you take care of the nutritional requirement of the patient during procedure, during surgery?
During surgery, patients will be on intravenous fluid to give both the maintenance and then to also give patient the deficit that he might have lost from the bleeding as a result of the perforation.
Okay, if your patient develops atrial fibrillation, what are the extra things that you have to keep in your mind in order to manage the patient?
If the patient develop atrial fibrillation, the atrial fibrillation could either be from the hypokalemia or from sepsis. So in that situation, I want to give patients to control the atrial fibrillation. So patients will need IV amiodarone 300 milligrams that will be given within about 10 to 20 minutes. Then patient will be placed on 900 milligram. Patient will have a cardiac shock, and the patient will continue 900 milligram of IV amiodarone over the next 24 hours. And patient will be on ECG monitoring both before the surgery and then after the surgery. And patient will be managed in the ICU.
Okay. How would you know if patient is suffering from toxicity of amiodarone?
The toxicity of amiodarone, the BP, a patient may have hypotension.
Yes. And
That's only.
Amiodarone is the third line of medication that is used. Why didn't you go for beta blockers?
I didn't get you, ma.
Yes, amiodarone is the third line of medication that you use in order for the cardiac irregularities. Why didn't you go for the beta blockers, which is the first line?
Okay. Yes, I can also use beta blockers.
Yes, but what is the caution that you have to take with beta blockers? This is
Yes,
what I'm asking in other words.
Yes, for beta blocker, patients can have bradycardia could happen, and then patients could have
There are other prescription requirement of consciousness as well when you're writing beta blockers. One should not write it for the young patients, and
I will check up that more.
okay, right, yes, you have to, because you should know it, not for the renal compromised patients as well. What about a patient, because this patient is already taking patient has osteoarthritis and taking NSAID, so is it okay to use beta blockers with this one? Because beta blockers will again cause constipation and leg edema and dizziness and headache and palpitations, and patient has atrial fibrillation, so patient will have palpitations as a side effect of beta blocker. So you would not be able to differentiate this symptom from the patient's current condition, so you have to be conscious. Okay. Yes, Belvin, thank you. Okay, ma'am. And here is your question. Right. So if you have read and understood considering this surgical pathology patient, kindly tell me what is the pathophysiology behind the condition that you think patient is suffering from?
So in this clinical scenario, patient has only abdominal pain and low phosphate and high parathyroid level.
Yes,
So
and decreased 125
decrease,
dihydroxy. Yes. D levels.
yes, decrease 125 dihydroxy cholecalciferol. So this may be a case of secondary hyperparathyroidism.
Okay. So
Yes.
what might be the pathophysiology behind it? What is causing this condition?
So due to fall, there is a renal impairment which causes the fall in the 125 dihydroxycholecalciferol in the circulating blood. So there will be fall in the serum calcium level, and which stimulate the parathyroid gland to secrete parathyroid gland, and the parathormone is released from the parathyroid, and which causes the serum calcium level to be elevated.
Can you, if you are asked to tell the gross pathology seen in these sort of patients, what would you say?
So the gross pathology of this patient, ma'am?
Yes. Of the condition, how would the patient present?
So
Okay, we'll come back to that.
It will be a
Can you
case of
tell-
renal
Yes.
failure.
Yes. Would there be
The-
shrinkage or would there be enlargement of the kidney? What else would be there?
There will be enlargement of kidney.
Yes, with the cyst, multiple cyst formations. Okay, good. Can you please tell me
But
what?
I cannot see any picture here,
Oh,
ma'am.
sorry. Yes, I did show you. Yes, here.
Yes, thank
Can
you.
you
For that,
explain-
I cannot
Yes.
understand.
Can you
Okay.
explain the picture now?
Yes, this is enlargement of the kidney and showing multiple cyst formation. Also, there are areas of hemorrhage.
Yes, right. Can you tell me what is the pathogenesis of cyst formation?
Yes, ma'am. At first, the tubular cell undergo repeated division, and
Yes.
which causes formation of a outpocketing,
Yes.
and this outpocketing expand, and continuous cell division causes this outpocketing to form a saccular cyst, which will
Yes.
be filled with filtration, glomerular filtration from the afferent tubule, and then this outpocketing, there is progressive expansion, and ultimately this is separated from the parent tubule and form a saccular cyst, isolated cyst. This isolated cyst now is filled with transepithelial secretion. Now
Very
these
good.
isolated cysts again progressively relentlessly expanded, and which will be due to the progressive repeated division of the tubular epithelial cell, also allow it will be filled with transepithelial secretion of water and salt,
Sodium chloride.
also sodium
Okay, good.
chloride.
Can you name few other organs which also can present with cyst formation?
Yeah, there are some organs which can be also have cyst formation, like liver, spleen, pancreas, ovary,
yes.
and as well as lung and intestine.
Okay, these cyst formation, what are the complications that they can lead to?
Yes, sir, due to this cyst formation, there may be renal failure, and there will be hypertension, there will be pain, and also infection.
Very good. Okay, can you please tell me what is the mode of inheritance in case of adult polycystic kidney disease?
Yes, the mode of inheritance is autosomal dominant.
Yes. Which genes are involved in it?
The genes are adult polycystic APKD1 and APKD2.
How adult polycystic kidney disease is different from child polycystic kidney disease?
Mm, Can I answer later?
Yes. Okay. What are the treatment options that you can offer to the patient with polycystic kidney disease?
Yes, the treatment option is if it is large enough and causing pain, severe pain, so surgical excision, sorry, nephrectomy.
Yes.
can-
Right. Okay. Kidney failure is already there, so you
Yes,
are doing nephrectomy. So
yes,
the other option would be kidney
infection and
transplant.
renal transplant, right,
Yes.
ma'am?
So when you're asking for, when you're offering the renal transplant, what are the things that you have to keep in your mind?
So when we go for renal transplant, we should at first do ABO matching and
Yes.
HLA typing.
When you're considering HLA typing, which one is the most considerant one or the
So
most
the
important one?
most important is DR.
Yes. Okay. Right. These proteins, they can be okay located. Okay. What are the possibilities once you are going for renal transplant? So what are the possibilities which you should be mentally prepared for when it comes
Yes.
to?
So there may be rejection.
Very good. Yes. So what are the types of renal rejections that you can
Yes,
come
there are four
across?
types of rejection. Yes, ma'am. There are
Yes.
four types of rejection. This number
Yes.
one is hyperacute rejection,
Yes.
accelerated acute, and chronic
When
rejection.
is it called hyperacute graft
Yes,
rejection?
the hyperacute rejection is usually occur due to preform antibody, and when you just release the clump of the vessel, then the hyperacute rejection occur just immediately after release of the clump, and the kidney appeared as mottled and dusky, and
Yes.
just immediately after the release of clumps, madam, and it is due to the
Okay.
preform antibody.
Right. Once you're going through or you're asking the patient for renal transplant, you'll also ask for immunosuppressive medications to be taken for lifelong. What
Yeah,
are the
yeah.
conditions when you are forced to stop immunosuppressive medications?
So when we forced to stop this immunosuppression, madam?
Yes, when?
Yes, if patient lymphoproliferative disease developed um, after transplant, after use of long-term use of immunosuppression,
Can lead to, yes, I want you to think, it can lead to malignancies of several types, right? You may be heard of squamous cell carcinoma of the skin, cervix,
yes,
locus, lymphoproliferative conditions. So when a patient
proliferative.
presents with a malignancy, right? You've already transplanted, patient is taking immunosuppressants, and now patient has presented with malignancy. Now you are forced to stop immunosuppressants. Also, you are forced to remove the transplant.
Yes, madam.
So yes, yeah. The next question was how to treat the complications or how to take care of the complications. So stop the immunosuppressions, remove the graft.
So yes, I will stop the immunosuppression,
Yeah.
and I will go for chemotherapy if there is malignancy developed, and I will remove the grafted kidneys, and
Yes. So that's,
I will
yeah.
start the anti-CD2 antibody. I can.
Thanks. Thank you. And here is your question. Right. So if you have read and understood, considering it surgical and augmentation, kindly
Yes, madam.
tell me, yes. Can you kindly tell me if you can identify number 13?
Number 13.
Yes, please.
Indices, extensor indices.
Okay, we'll go through it at the end. Okay, can you tell me what is 16?
Extensor retinaculum.
Can you please tell me the attachment of extensor retinaculum?
Extensor retinaculum. It is attached to the distal end of the radius and the ulnar, distal end of the ulnar
And
and
yes,
pisiform bomb.
how many
Pisiform bomb.
tendons pass through it, and with how
How
many
many?
synovial?
There are eight synovial sheaths that passes through it.
You sure? Okay, right. If you can identify three, right?
Three, yes.
Yes.
It is a branch of the radial nerve.
You are telling me.
Radial nerve.
I'll tell you later. Okay.
Branches of the radial nerve.
So what is this 5? It's red.
Right. This is the palmar digital arteries.
Okay. Yes. What is the nerve supply of the dorsum of the hand?
Radial side, radial nerve, while
Okay.
the index, middle, and ring finger median nerve, and the ulnar nerve on the little finger and half of the ring finger.
Yes. Okay, good. Coming on the right hand side image, this
Yes.
area, it has a special name. Can you identify this area?
Anatomical snuff box.
Yes. Can you tell me the boundaries of an anatomical snuff box, please?
Yes, radial side, extensor abductor pollicis longus is extensor pollicis brevis, and on
Yes.
the medial side, this is the extensor pollicis longus.
Yes.
And
What
the
about-
skin
yes.
and superficie and
Yes.
on this roof.
And there are certain carpal bones as well involved,
Yes.
maybe in the floor.
Radial stellate,
What are the
trapezium.
contents of an anatomical snuff box?
Radial artery, and radial nerve.
Okay. Right, we'll move on. In this image, if you can please identify number 8.
Number 8, where is the cursor, madam? Number 8 cursor.
Yes, here.
Yes. This is the flexor carpi radialis.
Okay, and can you please also identify 16?
16. 16 is the, I will tell you 16. Flexor, 16.
And 25.
This is 16 and 25.
Yes, 25 is here, where it matters, but yes.
Yes, 25 is the ulnar artery and 16 is the radial artery.
Okay, can you, yes, okay. Or maybe these are the nerves, okay. So
Yes.
if there are, if it's median nerve, can you tell me the sensory and motor distribution of the median nerve in the hand?
Yes, 16 is median nerve, sorry. And the 16, the 18 number is palmar branch and the 19 is a recurrent branch of the median nerve.
Yes,
the
just tell
palm.
me their sensory and the motor distribution of the median nerve, please.
Yes, the sensory
In the
distribution
hand.
is in
Yes.
the hand. 18 is palmar branch sensory distribution. 19 is the recurrent branch of the median nerve. And
Yes,
then
what I
other
want you to tell me that median nerve in the hand supplies which muscle?
Thinner muscles, opponent's pollicis, flexor pollicis, abductor pollicis muscle,
And two lateral two lumbricals.
lateral two
Yes.
lumbricals, and flexor digitorum profundus lateral two. These are the median nerve, and flexor digitorum superficialis is
Okay.
also supplied by the median nerve.
Moving
Yes.
on to the right hand side image. Yes,
Yes.
this 19 is which structure, please?
Flexor retinaculum,
Kindly
flexor
tell me the attachment of flexor retinaculum.
medially pisiform bone and laterally trapezium.
And
Trapezium
yes,
and laterally and trapezium and the scaphoid and trapezium, and medially pisiform and hook and hamate.
okay. What are the structures which pass through
Yes,
or pass
flexor
below the flexor retinaculum?
pass below the flexor reticulum, flexor digitorum superficialis, foretendon, flexor digitorum profundus, foretendon behind it, flexor pollicis longus, one tendon, median nerve. And there is a controversy that flexor carpi radialis is not in the tunnel, but it is in the sheet, but it is controversial. It is outside the tunnel, flexor carpi radialis.
Okay, there are certain things which are very famously asked in this picture. It's number
Yes.
31, if you can identify, please.
31 is ulnar artery.
Superficial palmar. Okay, what is 30, please?
30.
Just 30.
30 is the 30. It is the 30 is superficial ulnar. That is the superficial palmar arch radial artery.
So radial artery. If
Superficial.
you
palmar.
can tell me 27.
27 is the radial artery.
30, you said radial artery. Okay, what is 29?
29. 29 superficial palmar arch.
Okay, this is palmar arch. So this palmar arch arises from which vessel?
Ulnar artery. Ulnar
Okay.
artery.
So this is ulnar artery and this is palmar arch. This is radial artery. So what is this 27?
30 is the branch of the radial artery. 27. That is the
Yes.
principus. I think it is the deep palmar artery
Okay, tell me
or
what
pollicis artery.
how the superficial palmar arch is formed.
It is formed by the continuation of the ulnar artery.
Okay, can you please tell me where the tendons of flexor digitorum superficialis and flexor digitorum profundus insert?
Flexor digitorum superficialis insert at the base of the middle phalanx, while the flexor digitorum profundus pierces the superficialis tendon and inserted into base of the distal phalanx.
Yes, how would you test flexor digitorum profundus?
Digitorum profundus, I will stabilize the fingers, and
Yes.
then I will just flex the distal phalanx, while I will hold
Proximal.
the other proximal interphalangeal joint.
Yes. Okay. Right. If you are asked to do a test to test the ulnar artery, Allen's test, how would you do it?
I will ask the patient to clench his fist, and then I will close the. I will block the both arterial supply, radial and ulnar. Then I will ask the
For how
patient
long?
after a few
For
seconds,
how long?
at least 5 seconds. 5 seconds.
Okay.
Then I will ask the patient to open his hand, and then I will leave one side of the artery, either radial or ulnar. Then I will leave the another side of artery and check the blood flow with after 5 seconds.
Okay.
Is it
One last
going?
question. Can you please tell me why the hand grip is more powerful in extension as compared to flexion?
Because on extension, there is a tension in the flexor digitorum superficialis and profundus. So grip will be more powerful due to there is a strain on extension on the tendons.
Okay, good. Thank you.
Yes. Madam, I want to ask this question that in exam,